Good afternoon. I am Victoria Bordon from the Ghent University Hospital. It's an honor for me to present this webinar. This is about beta thalassemia major and allogeneic bone marrow transplantation. Here are my credentials. As I said, I work in the Ghent University Hospital. I am a staff member since 2002, and I am in charge of the pediatric transplant, hematopoietic stem cell transplantation program, and I am author and co-author of more than 50 peer-reviewed papers in relation to this topic. I have no potential conflict of interest to report. I am beginning with a small introduction about beta thalassemia. Beta thalassemia is an autosomal recessive, beta thalassemia major is an autosomal recessive disease caused by the mutation in or near the hemoglobin B gene, and this results in reduced or absence of production of the beta globin protein. Up to now, there are 350 disease-causing genetic mutations that have been identified. Beta thalassemia major is an inherited hemoglobinopathy that requires lifelong red blood cell transfusions and iron chelation therapy to prevent complications due to iron overload. We can classify beta thalassemia in beta thalassemia minor or trait. These patients of these people, they are not patients actually, are people who have the beta thalassemia trait. They have the heterozygous mutations, but they do not need transfusions. Beta thalassemia intermedia, these are mainly patients with an heterozygous mutations, but with hemoglobin that are 10 grams per deciliter or less, and they need sometimes transfusions. And the really disease is the beta thalassemia major, that these patients are homozygous for the mutation and they need transfusions. We can also classify beta thalassemia taking with the phenotypical aspect. We can classify in non-transfusion dependent thalassemia and transfusion dependent thalassemia. This is somehow a new classification. Beta thalassemia major usually presents clinically between the ages of 6 months and 24 months with severe and progressive microcytic anemia, failure to thrive, development of hepatosplenomegaly, icterus, and bone remodelation, mainly in the face. Why I chose this topic, and this is about the prevalence. About 1.5% of the global population, this is between 80 and 90 million people, are carriers of beta thalassemia. And 60,000 children are born annually with asymptomatic beta thalassemia, mainly beta thalassemia major. Beta thalassemia has been more common in certain regions of the world, such as the Mediterranean, the Middle East, and Southeast Asia. The prevalence of the beta thalassemia is increasing in other regions, including Northern Europe, primarily due to migration. We can treat the beta thalassemia major in two ways. We have a supportive treatment of conventional treatment. This is the hypertransfusion program in association with iron chelation. And we have two curative approach, the allogenic hematopoietic stem cell transplant. This is the topic of our discussion today, and the gene therapy. But first of all, should we transplant these patients? Why this question actually? Beta thalassemia is a non-malignant disease. There are alternative treatments available. In the future, probably less toxic therapies will be available also. And in my clinical practice, there are social aspects that we have to take into account. Many children are of less fortunate families and these families have many different needs. The parents of the children that I see frequently are low schooled and sometimes analphabets. There are major languages obstacles and sometimes major cultural aspects to take also into account. This is why I ask this question. To can answer this, I want to take you to do two interesting papers. One is of Kaoki et al. And the other one is Baron-Kiani et al. We know that at this moment, allogenic transplant represents the only effective and viable approach to cure beta thalassemia major. And there is a high rate of success, especially in the pediatric setting. If we take a look in the EBMT guidelines, the European Bone Marrow Transplantation Guidelines, this says if there is a much related donor, a sibling, this is a standard of care by beta thalassemia major. If there is a MAT of mismatched donor, is a clinical option. We know also that in beta thalassemia major, the transplant is cost effective when compared with lifelong supportive therapy with transfusions and iron chelation. First of all, we have here the one small resume of the paper of Donatella Baron-Kiani of the EBMT registry. This cohort of patients is 1,493. A patient transplanted in 127 different centers worldwide. The vast majority of these transplants was performed in children with a sibling donor. And in this paper, we found a survival of 88% and a thalassemia-free survival of 81%. The very interesting paper of Kaoki et al. Is a single center study, but it's a study of a period, it's a retrospective study, but it's a study of a period of 30 years. What gives us insight in the very long-term survival of these patients? Here, this paper compared the outcome of 516 children and adults with beta thalassemia major treated with transplant or with conventional therapy. Overall survival and thalassemia-free survival of 258 thalassemia patients undergoing transplant was compared to an age-sex matched thalassemia non-transplant patient. The median age was 12 years, so we see that mainly the patients in the population were children, but of course there were also young adults. And these patients underwent sibling transplant of unrelated transplant. Of the children, we see that 20% had the classification risk 1, the Pesaro classification risk 1. 32% was Pesaro classification class 2, and 8% was Pesaro classification class 3. The median follow-up was 11 years. This slide shows the donor and conditioning characteristic. The donor, 170 patients, were transplanted with an HLA identical sibling. 3 patients were transplanted with their HLA pheno-identical mother, and 85 patients received an allograft from an unrelated donor. Conditioning regimen was busulfan-based or BU-based in 80% and treosulfan-based of treo-based in 20%. The results. So the 2-year, 5-year, and 10-year overall survival was lower in the transplant group compared to those with conventional therapy. And we can see here the 2-year overall survival was 88% in the transplant group and 99% in the hypertransfusion of conventional therapy group. The 5-year was 87% in the transplant group and 98% in the transfusion group. And the 10-year overall survival was 86% in the transplant group and 95% in the conventional therapy group. So this is somehow logic, because when we are doing a transplant, we are taking all the risk up front. But this very long-term analysis took a look also in the 13-year-old overall survival. And we see that here there is no anymore difference between the transplant group. They had a total transplant-related mortality of about 13%, comparing to the thalassemia group. They had also the probability of dying of cardiovascular events, mainly due to iron toxicity, from about 12%. If we take a look in pediatric patients under the age of 60, we see that the overall survival is higher, 91%, and thalassemia-free survival of 84%. Also, we see that children with class 1 and 2 Pesaro classification have a better overall survival of 96% and thalassemia-free survival of 90%. If we compare with the Pesaro 3 classification, and this is overall survival of 74% and thalassemia-free survival of 66%. These patients have also a graft versus host grade fear, what is our problem, of about 10%. And cumulative incidence of chronic GVHD of 13%. This group have a reaction cumulative incidence of almost 7%, and the latest episode of reaction was diagnosed 17 months after transplant. Here you can see the Pesaro classification, what takes into account the presence of hepatomegaly, the presence of liver fibrosis, and the history of iron chelation. Also, you see here in the green curve, the overall survival in conventional therapy. The overall survival in the transplant group is the blue curve. There is no difference in these curves, and the thalassemia-free survival after transplant, which is how good. So we will take a first look at these results also. These are the percentage of reaction, and you find here the BU-based conditioning and the treo-based conditioning. And what we found here is that patients with trio-based conditioning have a reaction of almost 15% in this study, and in the VIEW base have almost 5%. This is different. There is more, in this study was more risk of reaction in the trio base. We also see, this is the adult transplant and the unrelated transplant, we see that in these two categories, these patients present trio-based, patients transplanted with trio-based conditioning had less GVHD than those transplanted with busulfan-based conditioning regimens. So this is what I told you, patients transplanted with triosulfan-based conditioning regimen have somehow less, probably somehow less graft versus host disease, but at least in this study, more risk of reaction. There is another study, a study of Matthews et al. This showed that patients suffering from class 3 Pesaro classification and older than 6 years after a conditioning with triosulfan, with the triosulfan-based regimen, these patients had a better overall survival, less veno-occlusive disease, and also higher thalassemia-free survival. These things we have to take into account. Again, should we transplant these patients? We know that when we are speaking of transplant, surely in pediatrics, not everything is overall survival and transplant and thalassemia-free survival. A very critical aspect is quality of life. So we take here the paper of Lanasa et al. This shows the long-term health-related quality of life, evaluated more than 20 years after hematopoietic stem cell transplantation for thalassemia. And in these results, in the blue bars, you can see the thalassemia, the thalassemia patients transplanted, the patients who received transplant for thalassemia. And in the red bars, you see the patients under conventional therapy. And patients who received transplant had less role limitations, had a better physical functioning, had less body pain, and had also a better emotional functioning. So we see here advantages in quality of life in the long-term follow-up. Here, the same paper showed the impact of GVHD in physical health and in mental health, and we see that patients with GVHD have less optimal general health, as we expect actually, and also their patients without GVH have a better mental health. Here are the patients transplanted in this study before and after the age of 15, and we see here some advantages to transplant in young age. And we come to the conclusion after the lecture of this paper. Should we transplant these patients again? Probably yes, we should transplant these patients. With an HLA identical sibling, better that we transplant at a younger age, younger than 15 years. We have to avoid GVHD, and we have to avoid reaction. And what kind of conditioning regimen we will choose for these patients? As I show you, triosulfan shows some advantages, probably less graft versus host disease, but also some disadvantages. Significant more reaction, at least in one study. So we take a look to another study, the study of Luftinger. They compared busulfan fludarabine and treosulfan fludarabine-based conditioning regimens in children with beta thalassemia major. This is an EBMT retrospective multicenter registry study. The patients that were included were children younger than the age of 18, and they received the first allogenic transplant for the transfusion-dependent thalassemia. And here were sibling donors and much unrelated donors also included. This study includes 772 patients, 410 patients received the Buflu-based conditioning regimen, and 362 received the Treoflu-based conditioning regimen. The patients receiving Buflu were somehow older than patients receiving the Treoflu in this study. The median age of a transplant in the Buflu-based conditioning regimens was 8.6 years, and the median age of patients receiving the Treoflu-based conditioning regimen was 5.7 years. There was also a difference in the homogeneity of the group. Patients receiving the Buflu-based conditioning regimens received different type of chemotherapy combinations. But the patients who received the Treoflu was very homogeneous. Almost always these patients received Treoflu thiotype. This was a most homogeneous group. Also, there was a difference in the in vivo T-cell suppression with ATG or alemtuzumab. This was more frequent in patients who received the Treoflu-based regimens. We see the overall survival in the two groups is excellent. But we see here also the 2-year incidence of a second transplant was 4.6% in the Buflu-based conditioning regimen versus 9% in the Treoflu-based conditioning regimen. There was an overall incidence of GVHD of 7.7% and von Grad 4, what is our clinical problem, for 12.1%. The 2-year incidence of chronic GVHD was 13%, but from chronic extensive GVHD was 5.2%. In this study, Luftinger didn't find any difference between Buflu-based and Treoflu-based regimens and GVHD. But still, Treoflu and thiotype are increasingly becoming the standard of care in non-malignant transplant in Europe. And this seems appropriate in order to minimize the risk of short-term life-threatening complications in patients with thalassemia, a transfusion-dependent thalassemia. Also, there is an excellent 2-year overall survival, and we know that there is some early data that could show some advantage for the Treo-based conditioning regimen regarding fertility preservation, but it's still very early to make some definitive conclusions. So when we are choosing a conditioning regimen, we have to evaluate the risk and evaluate the benefits. And at this moment, it seems that the Treoflu conditioning regimens, Treoflu thiotype plus ATG, is a good conditioning with many advantages, but with probably more risk of reaction. The problem of this conditioning regimen and the problem of beta thalassemia is that these patients have more risk for reaction and autologous reconstitution, as I already mentioned. So how can we reduce this problem? We can make some kind of immune suppression before the transplant or after the transplant with better tailoring of sirolimus and CellCept. These are all things that we can do. So I take the paper of Yasara et al. This is a comprehensive review of hydroxyurea for beta thalassemia. And we know that hydroxyurea in beta thalassemia inhibits the ineffective erythropoiesis, what is a major problem in this disease, and also causes bone marrow suppression. Also, the papers of Karimi et al. And Cario et al. Show that hydroxyurea is the first-line treatment of extramedullary hematopoiesis. And I know that there are different centers that are using, me inclusive, hydroxyurea with 2 or 3 months before the start of the conditioning regimen. But sadly, there are no papers with this, the evaluation of the hydroxyurea before conditioning regimen. So I cannot make any kind of result. I have no results about the benefits or problems of this approach. But we have a paper, a very interesting paper of Brachet et al., published in Bone Marrow Transplantation 2004. And this group analyzed the impact of hydroxyurea in other kind of patients, in sickle cell anemias. And they analyzed the hydroxyurea before start of the conditioning regimen. And they saw lower incidence of rejection and better engraftment in these patients. So I think this hydroxyurea approach is something that we have to consider and would be ideal if we can make a study and have better data. Now I am moving to the last part of our talk of this webinar, and these are the novel treatments. I will begin with gene therapy, with a very sexy item always. So gene therapy by gene addition, this is the transfer of a healthy copy of the beta globin gene into target cells using modified viral constructs as delivery vehicles. This has been the most developed gene therapy approach up to now, and the self-inactivating lentiviral vectors have proven to be the safest and most effective means of delivery at this time. There is a commercial product with the name of Zynteglo, but sadly this is not available outside the USA. I have also to say that this approach costed per patient $2 million. And in October 2020, Bluebird Bio announced the withdrawal of its regulatory marketing authorization for Zynteglo from the European Medicine Agency for the European Union. Then we have drugs that are targeting ineffective erythropoiesis and iron dysregulation. We have here the totatacept of ACE-011. Has shown to correct ineffective erythropoiesis. There is a small phase 2 study conducted in 16 transfusion-dependent thalassemia patients that show that the majority of these patients, 2/3 of these patients, treated with higher doses of totatacept achieve a reduction of 30% in red cell transfusion requirement. Also, this drug exhibited an overall good safety profile and was tolerated by most patients. Then we have the luspatercept. This is a recombinant fusion protein that enhances erythroid maturation. It is the most recently approved therapy for patients with transfusion-dependent thalassemia and is approved by FDA and EMA. And it has Reblozyl is the commercial name, and can be used in patients older than 18 years. This is not approved in pediatrics and is recommended at a starting doses of 1 milligram per kilo once every 3 weeks by subcutaneous injection. And with the luspatercept, that's the latest approved drug, I come to an end of this webinar, and I want to thank you for your attention, and I want to thank the ERN Transplant Child for being supportive and for inviting me to present this webinar. Thank you.